diseases, immunization, critical care, and asthma. So with this brief introduction, I hand over it to Dr. Ramakant Patil sir to introduce our speaker for today and open the forum for and to take it ahead. Over to you, Dr. Ramakant sir.
Thank you, Dr. Sanjay. So nice of you for those pleasant words. And I will like to acknowledge presence of Mr. Rajendra Pandita sir, who is from Samarth Lab, Mr. Prashant Dave. And I will really like to congratulate Samarth Pharma for this wonderful interventions, particularly for pediatric formulation. I was just discussing with Mr. Pandita that Samarth has been really, whenever we had short supply of digoxin 2 decades back, 3 decades back, and it was made available by Samarth. Also, nobody had come with the liquid preparation of furosemide, and Samarth has been innovative in, and I hope more and more such preparation which are not in a suspension or syrup formulation, and newer drugs which are not available in our country will be made available by Samarth. I will also like to congratulate for this wonderful activity of them of Pedia Connect, and particularly for today's speaker, who is very good friend of mine, Dr. Lalit, and very down to earth person, even if a subspecialty pediatric cardiologist. He has got so many credentials. He has been he's an interventional pediatric cardiologist and adult congenital heart disease specialist. He's a director of Gunwant Child Care Center and also many other 2-3 hospitals in Nasik. He was the person who was doing, like people do come from metros to the tier 2 cities or tier 3 cities, but he was the person who was going from tier 2 cities to tier 1 cities as a visiting consultant in so many corporate hospitals in Mumbai. And most important, my first-hand experience as him as an interventional cardiologist, we had put in a femoral catheter, and it got broken, and the piece was like in femoral artery, and we were very desperate. And we called him, and he reached within 3 to 4 minutes with his anesthetist, and with the utmost patience, he took out that broken piece from the femoral artery. And hats up to him, he is available to us for any time. His academic credentials are too many. I don't want to take the time to reading out his academic credentials. Everybody knows, but as a person, as a co-medico, his helpfulness is more worthy of mentioning over here. And he has been so much experience as a consultant in Indraprastha Hospital, in Rabindranath Tagore Hospital, International Institute of Cardiac Diseases in Kolkata. And here it is mentioned only smallest baby of 950 gram, but recently 2 months back, he has done it in some 650 grammer or 750 grammer baby. The interventional cardiology was done. Probably he has not mentioned it over here, but it was done in Nasik. So we have got a giant and gentle giant, I will like to say, in the field of pediatric cardiology, to discern and decipher us on the management of heart failure and in congenital heart diseases, whether in heart failure or other things. And we will be definitely having an enriching experience and enlightenment. So over to you, Dr. Lalit. The dais is open for you.
Yes, thank you. Thanks a lot, sir, for that kind words. I hope I will live up to your words. And thanks a lot for that generous and kind words. So without too much of more delay, I think we'll go straight into the topic. Can I share my screen?
Yes, sir. Yes, sir. Yes, sir. You can.
Yes. Can you see the screen, the slideshow, PPTs?
Yes, we can see it, but you can
make it full screen.
Yes. Again, some problem with the technical glitch is there, I think, with the video. Yes.
Yes.
So
if your internet connection is unstable, you can put up your video if it is possible. Try and do that.
Yes, so that this glitch may go away. Yeah. Is it okay now?
Yeah. Loud and clear.
No, yeah. Okay, so I'll just restart. I hope this is okay now with the video also. So
Yeah, wonderful.
of the congenital heart disease made easy. So we'll go straight into the topic. Yes. So this is my favorite slide in all the presentations. Most of the times I would like to put this kind of this first as the first slide. Why it is important to know about the congenital heart disease. So we are going to spend our next 45 minutes to 1 hour for this. So why it is important to listen to this talk, congenital heart disease? Because the incidence of congenital heart disease is 1 per 100 live born babies. So suppose if someone is seeing 100 new babies, new patients in a week's time, he should see or he should be able to pick up at least one congenital heart disease. So if you are not making one congenital heart disease diagnosis, then definitely you are missing. You need to revise something and put more efforts to diagnose more and more disease patients. In the due course of time, we will come to know that this is very easy to diagnose the congenital heart disease, and it is very difficult to miss this congenital heart disease. Because during our training in the medical college, nowadays the training has been changed, and in the private practice, we learn more about the congenital heart disease. But initially, our total, as a pediatrician, our main focus was LRTI, respiratory illness, GI illness. And if something is left out of this, then the PM and other system. But congenital heart disease is really something is not well taken care. Then the major cardiac illness will affect the growth and quality of life of your patients. It needs timely intervention. If a large VSD or large PDA, you refer in time, it will get operated or gets closed with the device in time, and baby or your patient will live completely, absolutely normal life. Throughout life, you will not have any kind of problem. But the other way of this, if the patient gets delay for the diagnosis and the further treatment, he may go for the Eisenmengerization, and we have n number of Eisenmenger patients who are not doing well, and over the period of time they will succumb. And this is not only the patient, the whole family has to suffer. So we want productive society. We don't want someone as a burden on the society. We want the productive society and the better healthy persons. Then almost all the congenital heart diseases are treatable. This is underlined, almost all, I mean it. Only exceptional is the hypoplastic left heart syndrome. Yes, we have treatment for that also, but it is at present multi-stage surgery with outcome is guarded. So except hypoplastic left heart syndrome, we have almost all of the congenital heart diseases are treatable. So the next point comes is, what about the cost of the treatment? If even if it is diagnosable, treatable, then who can afford? With the present government availability or the funding, with the help of the schemes, and we have n number of NGOs who are coming forward to support this kind of patients. So it is not really a problem. The cost is not the problem. We can tackle with the almost all cases. So next is, this is a very basic, that is the NADA criteria has been given ages before, and still it is valid in the today's era of the practice for the practicing pediatrician. So in brief, I would like to say that is a major and minor criteria. In the major, there is a systolic murmur which is grade 3 or more. That is the murmur which is easily audible. You put the stethoscope on the chest wall of the baby or your pediatric patient, and you get the murmur. That is the grade 3 or more murmur. Any diastolic murmur, any grade, even if it is grade 1 of diastolic murmur, presence of cyanosis, patient in a congestive heart failure. Any four, you have to make sure that your patient is not having any one of these four things. Even if one thing is present, you get one sign or symptom in your patient out of these four, suspect that this patient is having the congenital heart disease and referred him to the pediatric cardiologist for the echo. Then we have something like the minor criteria, that is a systolic murmur grade 2 or lesser than that. Then abnormal S2. Abnormal S2, again, it takes years of experience to pick it up. I wonder, and I know that even the RD Patil sir is there, who sends the patient to me with only abnormal S2. look for the particular diagnosis, and I get the CTG diagnosis. So these skills, I know it is not easy. You need to put your years of practice and experience to get that kind of, to pick this abnormal S2 or the single S2. It is not possible, but yes, if you can put your efforts, you will definitely learn it. And abnormal ECG in the pediatrics, we don't do that much commonly ECGs, but yes, in a SVT or other patient, it is valid. Blood pressure, again, any child more than 3 years of age, it is recommended, and you should not miss the blood pressure. So all the patients with more than 3 years, preferably all, and not more than 3 years, not a single patient should go without examination of the blood pressure. And abnormal chest X-ray. Again, the chest X-ray is easily available, so at least you can make out the cardiomegaly on that. So any of the two of the minor criteria present, send this patient for the congenital heart disease evaluation. Then what are the tools you require for the diagnosis of a congenital heart disease? Stethoscope you are carrying, but most of the times our patients are cranky, irritable, will not allow. But put that little bit extra efforts and extra 30 seconds, few seconds more time to pick up that murmur. If you are able to hear that murmur, definitely there is a congenital heart disease. Most of the times, what will happen? It can be the innocent murmur, which may be present in the pediatric patients, most of the up to the 50% of the times. But don't bother about that. If it is a murmur is there, this patient needs evaluation from the pediatric cardiologist. The next most important tool of your practice is pulse oximeter, and it is not only the pulse oximeter. You should get the proper waveform like this. It has been shown here. If the baby is cranky, throwing his limbs here and there, you will not get the correct waveform, and you will miss the perfect saturation in this baby. So unless and until you see this kind of waveform, don't take that saturation and don't document it. You can train one of your staff. It takes really more time. Sometimes it may take 2 to 5 minutes also to get the pulse oximeter saturation reading of one of your babies. Then next most important is the clinical examination. Tachypnea, these are the subtle findings that tachypnea at rest, baby is comfortable as such, no other problems. You know, your respiratory distress patients will be having the respiratory distress, he is not well by look. But the congenital heart disease patient is tachypneic at rest, but as such, there is no signs of lethargy or another symptoms will be there. There will be the subcostal and intercostal retractions. There can be the hepatomegaly. And the most important is the syndromic phases. Any patient with the syndromic phases, you should suspect the congenital heart disease. High chances that this patient is suffering from the congenital heart disease. So clinical examination, these are the points one should not miss. Chest X-ray again to look for the cardiomegaly. Then suspicion of the congenital heart disease is the most important thing. If you are not able to suspect the congenital heart disease, the patient with the CHD with all the signs will be lying in front of you, and you will not able to pick up the congenital heart disease and refer him for the further evaluation. Then the classification, the congenital heart disease is classified. We know it is a cyanotic congenital heart disease and cyanotic congenital heart disease. In the cyanotic, again, it is divided into the two groups. That is the increased pulmonary blood flow, and another is the decreased pulmonary blood flow, where the tetralogy of Fallot's and similar physiology of physiology comes. And in another group, that is the acyanotic congenital heart disease, where the saturation is more than 95%. This is the patient with the congenital acyanotic heart disease. In this, again, it is divided into the two groups, that is the left to right shunt and obstructive lesion. So we will go into the brief of this. I think when I put on the video, the slides will not able to move. Yeah. So in the acyanotic congenital heart disease, saturation is more than 95%. In the left-right shunts, we have ventricular septal defect, we have atrial septal defect, we have both, that is the atrioventricular septal defect, then the patent ductus arteriosus, aortopulmonary window. In the obstructive lesion, we have aortic stenosis, pulmonary stenosis, and coarctation of aorta. In the cyanotic congenital heart disease, decreased pulmonary blood flow, we have top physiology, that is the all patients with the larger shunt or the TGA and the great vessels abnormality present along with the pulmonary stenosis. All these patients or all these illnesses will come into this category, that is the cyanotic congenital heart disease with the decreased pulmonary blood flow. While the another group is there, if there is the admixture physiology or the some lesion is there which is making the mixture of the oxygenated and the deoxygenated blood with this causing the cyanosis, and there is no pulmonary stenosis. So effectively these patients will behave like a large shunt patients. So in this there is a transposition of great arteries, total anomalous pulmonary venous connection, there is a double outlet right ventricle. We know that the whole deoxygenated blood comes to the right atrium from the SVC and IVC to the right atrium. From right atrium, it goes to the right ventricle. From right ventricle, it goes to the pulmonary artery, the deoxygenated blood, where it gets the complete blood gets oxygenated, and the whole of the oxygenated blood will come back to the left atrium. Then it goes to the left ventricle, and through the aorta, it will be shifted to the whole of the body. Circulation has been completed, the cardiac cycle has been completed. So any defect in between the atrial septum is called, we know that is the atrial septal defect. So usually left heart side pressures are high, right heart side pressures are low. So the shunting of the ASD is usually most of the times from the left heart to the right heart, from the left atrium to the right atrium. In ventricular septal defect is the disease where the ventricular septum is, there is a defect in the ventricular septum, and usually again the left heart pressures are high, right heart pressures are low. So shunt will be the left to right. PDA is the communication between the two great vessels. There is the extra vessel is going to be present, which is supposed to get closed by 24 to 48 hours. It has not been closed, so it is the patent. So with this background knowledge, we will go with the case-based presentation. So this was our first patient. He is a 2-year female weighing 9.7 kg, approximately okay for the 2 years old baby, but with the history of developmental delayed milestones, otherwise asymptomatic, and she has been referred to me for the 2D echo. Clinical examination. So why she has been referred? There is looks everything okay apart from the delayed developmental milestones. This is not the cardiac case. Of, one should suspect the CNS or something other HI or another things. Why she has been sent to the cardiac referral or the cardiac evaluation. On the examination, there was no visible cyanosis, no clubbing, no hepatomegaly. She was breathing absolutely normal, no tachypnea at rest, absolutely normal respiratory rate. On auscultation, there was no murmur. There was no murmur. Heart sounds, if you are able to pick it up, the P2 component of the second heart sound is loud compared to the A2. So this can suggest you there is a pulmonary hypertension. But only one finding was there, that this baby is having the syndromic facies. You can see, if you are able to make it up, upward palpable slanting fissure. Then the low set ears, obviously it cannot be make it out in this photograph. So the only reason for the cardiac evaluation of this baby was having the syndromic facies. And now what I got on the further evaluation. See the saturation of this baby. See on the clinical naked eye examination, almost including cardiologists, pediatric cardiologists, most of them will miss the cyanosis by naked eye examination. So it is mandatory to have the pulse oximeter in your OPD and document saturation of each and every patient. See this patient looking fairly okay with the saturation of 85%. And I have oxygen in my OPD. With that also it has came up to the 94. It is not gone beyond 95%. So definitely this is not a respiratory case. Most likely this is the congenital heart disease, which is having some kind of response to the oxygen. And so what it was. So echo has been done and the diagnosis of complete AV canal defect. See, complete AV canal defect by 2 years of age, it will go for the Eisenmengerization, or if not for the Eisenmengerization, it will go for the pulmonary vascular obstructive disease, where the PAH is irreversible and you cannot operate this baby. High likely, if this baby goes to the OT, he will not come out of the operation theater if the BSD and ASD has been closed. So it is mandatory to send this patient earlier. On probing the history, what was the history in this patient? There was a history of failure to thrive early in the infancy. There was a feeding difficulty early in the infancy. There was recurrent respiratory tract infections during the early 6 to 8 months of the life. And the baby child was doing well since last 6 months to a year time. So all this was pointing out something congenital heart disease was ongoing and it has been missed by ourselves. So we should not miss failure to thrive. There is no other cause but the baby is having failure to thrive. There is recurrent respiratory tract infection. So these are the subtle findings one should be look for. So this baby, most important, was having the syndromic phases, and we know that most of the syndromes will have associated congenital heart disease. And if you send this patient in time, it would have been operated and child would have been lived a normal life. In the photograph, you can see another patient with the complete AV canal defect who got operated at the age of 6 months and he is doing well. This photograph at the age of 1 year, and now that kid is more than 2 years. So the crux is you should not delay referring the patient. If you delay in referring the patient for the pediatric cardiac evaluation, you will miss the bus. The next case is from the neonatology, that is a 10-day-old baby, female baby with the irritability since last 2 to 3 days. There was refusal to feeds, progressively worsening respiratory distress since last 2 to 3 days. This I'll just cut short, and I'll show the importance. One point I would like to make. On examination, the pulses were not palpable. The baby it had came to me from the periphery, and the baby was literally gasping. Heart rate was shown on the monitor as told to me by the referring person from the periphery, from the rural area. It was 110 to 130. Saturation was 90 to 95%, and there was not satisfactory waveform. So I told initially only, if waveform is not perfect, don't go for it. But there was a hepatomegaly. And echo showed there is a severe LV dysfunction and severe pH. The echo has been done at periphery and cause of the pH is not known. So what to do with this baby next, and it has been referred to me. Just putting up the probe with this baby, there is a regurgitation of the mitral and tricuspid valve, severe LV dysfunction, and heart was beating like a canary. So the heart rate was more than 240. So in case of a tachycardia, very high rate, ventricular rate or rate is very high, where 180 or more than 200, do not rely on your pulse oximeter unless until you have your specified neonatal probe. Don't rely on that pulse oximeter and you will miss the SVT also. So this was the patient of the supraventricular tachycardia. Echo has showed the dysfunction and all, and ECG has been done immediately and diagnosis has been made. This patient was having the diagnosis of supraventricular tachycardia, was in congestive heart failure, and due to all these problems, he aspirated and all that problems. Obviously, with the adenosine, there was no response. Direct cardioversion is the treatment of choice. He has been revived and he was there for almost 8 days with us and revived and sent back in the sinus rhythm. He was with the maintenance propranolol dose. So importance of having the good pulse oximeter. If your pulse oximeter is not good, at least put the stethoscope on the chest wall and try to count the heart rate, not with the peripheral pulses. Heart rate one should not try to count in case of a tachycardia. At least put the stethoscope, you will get the idea. Yes, heart rate is more than 150, heart rate is more than 200, and you will refer accordingly. Then our next case is, this is the actual congenital heart disease. That is the 4-day-old neonate with the birth weight of 3 kg. He is not taking feeds and lethargic, very short course, that is only 5 to 6 hours. Birth history, absolutely okay. Full-term normal delivery. Birth weight was okay, 3.1 kg, 100 gram loss is okay, less than 10% in 4 days. He cried immediately, he or she, and accepted feeds immediately after the birth. On examination, baby is afebrile, heart rate is 150, respiratory rate is 60. Little bit borderline to say for the 4-day-old baby, RR of 60, but acceptable can be. On auscultation, S1 and S2 is normal. There is no murmur. Respiratory system, no abnormal heart sound, absolutely normal. So with this kind of presentation, this kind of history, what will come to our mind as a pediatrician or the neonatologist? Most likely diagnosis can be the dehydration, acute 5-6 hours, yes, but still it is a possibility. It can be the sepsis, yes, this should come to our mind as a first. Next is the feeding issue. With 5-6 hours, baby is NBM. Literally, should it cause the problems? You do to rule out all these problems, you do the blood sugar, you diagnose, you get the hypoglycemia. Yes, well enough. Your workup is okay, history is okay. Treat the hypoglycemia and for the cause of that, and you will be, most of the times you will be right. But you have not, what you have missed on the examination, where what are the things you have missed? You have not checked the pulse oximeter. The saturation of this baby is not done. So what was the saturation or the congenital heart disease or the pediatric cardiologist point of view? What can be the differential diagnosis which can in this baby? From my point of view, this can be the coarctation of aorta. This can be the severe aortic stenosis with the LV, severe LV dysfunction. Once the severe LV dysfunction will set in, there will not be any kind of murmur. Similar with the critical pulmonary stenosis. Yes, obviously the critical PS may show some kind of cyanosis. Another is the cyanotic congenital heart disease with the duct-dependent lesion. You have not checked the cyanosis saturation. This is the possibility cyanotic CHD with the duct-dependent lesion, or the cyanotic congenital heart disease with the increased pulmonary blood flow, where subtle tachypnea can be there, which can be missed also. So what you have missed and one should not forget is the saturation, hepatomegaly, pulse volume of the upper and lower limb. With the saturation, with one point of time examination, one examination will give rule out your whole congenital cyanotic heart disease spectrum. With hepatomegaly, it can be the shunt lesion or the increased pulmonary blood flow lesion. With the pulse volume of the upper and lower limb, you can rule out the coarctation of aorta. More or less. So in this baby, if you have seen the saturation of more than 95% with the normal pulse volume, and there is no discrepancy of the upper and lower limb pulses, no hepatomegaly, yes, you can go ahead with any of your working diagnosis. It can be the hypoglycemia, sepsis, dehydration, or whatever the other causes. But if there is a lower limb pulse is feeble or low volume compared to the upper limb, in neonate it can be difficult. But if your pulse oximeter comes to your help, that lower limb saturation is less than upper limb, the difference of more than 3% in the upper and lower limb, then this can be the coarctation of aorta with the PDA, which is giving the deoxygenated blood to the lower limbs. Then you can think of the coarctation of aorta and send this baby to the pediatric cardiac evaluation. If the saturation is below 85%, definitely this baby is having the duct-dependent lesion, needs emergency referral and further management. If the saturation is in between 85 to 94% on oxygen, this is a congenital cyanotic heart disease with the increased pulmonary blood flow. So how you will manage? Suppose this patient is having the saturation of 85% in room air and with oxygen. So how will you manage? You know, this is a strong possibility of the cyanotic congenital heart disease with the duct-dependent lesion. You don't have the easy access to the echo, your pediatric cardiologist is not there, and or you are practicing in the periphery. Whether to start the prostaglandin to this baby or not, does the chest X-ray will help you or not? Yes, chest X-ray will help you up to certain extent. If you get the chest X-ray like this, there is the oligemia or the egg on end appearance. You know, this can be the transposition of great arteries. Immediately start the prostaglandin and send this patient for the further care. If you get the X-ray of this kind, which is showing just the X-ray similar to your hyaline membrane disease of the preterm baby, where you cannot make out the cardiac ciliary and the respiratory shadows. So this, what can be the differential diagnosis from cardiac perspective for this baby? Only two diseases will come in my mind with this X-ray from cardiac point of view. That is the total anomalous pulmonary venous connection with the obstruction, that is the obstructed TAPVC, or the hypoplastic left heart syndrome with the restricted ductus arteriosus, or the restricted patent foramina of vein. And in both of these conditions, one should not start the prostaglandin. One should send the patient with what are the facilities available to the pediatric cardiac center as early as possible. If you get the X-ray like this, start the prostaglandin. If you see the X-ray like this, never start the prostaglandin. Another important diagnosis you can get with the one more ABG, that is the in neonate generally you may put the umbilical vein or the arterial access. If you don't have the access to the echo, you can get the umbilical arterial sampling, and if you get the umbilical venous blood sampling, and if it shows the PO2 is very high, more than 100 PO2, it is a diagnostic of infracardiac TAPVC. Without echo, you can diagnose this patient as an infracardiac TAPVC and send boldly to the pediatric cardiac center. Definitely, your diagnosis is going to be the perfect. So management wise, when to start the prostaglandin in a duct-dependent lesion? If the saturation is less than 80%, even if you don't have echo, start this patient in this unit on the prostaglandin and refer early. One should be cautious about the prostaglandin side effects. It can have bad kind of apnea. So if you start the prostaglandin, any baby with the prostaglandin, at least monitor 30 minutes to 1 hour. If you get the apnea, bad kind of apnea, intubate the patient and then only refer. Do not immediate start prostaglandin and immediately refer the patient in the ambulance. Baby may succumb due to the apnea on the way. And sometimes you can give the apnea prophylaxis, your caffeine and all that, the loading dose before starting your prostaglandin also. There can be the hypotension and fever with the prostaglandin, but that is not the serious adverse effects of the prostaglandin. One should be worried about the apnea only. If the basic rule is, if the saturation is not improving on oxygen, not to give oxygen to this baby, because whatever the ductus is remain open, that will also get closed with your high flow of the oxygen, and most of the times in the borderline term babies. So echo is mandatory in this patient, and early reference to the higher center is also important. Then coming to the management of the transposition of great arteries with the intact ventricular septum. The surgery has to be done within first 2 weeks of life, because by that time only the left ventricle is prepared. After the 2 weeks of life, LV will start regress and anatomical correction is not possible. And then the baby will go for the physiological correction, which is not good in long term. If you are able to achieve the complete anatomical correction in a TGA patient, the diagnosis is excellent. And once monthly, at least 4 to 5 patients with the TGA I get, and all in time, if referred, gets diagnosed in time, referred in time, operated in time, they have excellent prognosis. If in the duct dependent lesion, it is a top with the pulmonary atresia, one may need to go with the ductal stenting in the cath lab or the modified BT shunt, and later on he can go for the total repair. If it is a patient of a critical aortic or the pulmonary stenosis, balloon pulmonary valvuloplasty or the aortic valvuloplasty is the required treatment. Coarctation of aorta, it can be the balloon or the surgical. So this is how the one saturation will save you and gives you the diagnosis and further management. Only saturation and your careful clinical examination. Moving to the next case, that is the 6 days old term baby with the respiratory distress from second day of life. He was intubated and was on ventilator support with the saturation of 90 to 92% on ventilator with the FiO2 of 100%. Mind it, the FiO2 is 100%. In spite of that, saturation is only 90 to 92%. Echo is showing the severe PPHN, small ASD, which is shunting right to left, and he has been transferred for the further management. Strong clinical suspicion of a cyanotic congenital heart disease in this baby, in spite of a echo. See, the baby is 6 days old, and he has started with the respiratory distress since second day of life. By that time, if you have a diagnosis of severe PPHN, it should have improved in last 3 to 4 days, or at least it should have worsened. You know, PPHN, you try to give with the sildenafil, IV, milrinone, and all that stuff, whatever you have. In 3 to 4 days, he should improve or he should degrade. But nothing has happened. He is maintaining just the status quo. So strong suspicion of the echo can go wrong with the, if not, it is done by the qualified pediatric cardiologist. So get the echo done by your wherever your comfort level is high. And we have n number of this kind of patient. In this patient, this was the X-ray. It has been shown, sent to us, and we said, yes, no matter whatever is your echo diagnosis, this baby is going to have a TAPC, most likely the obstructed TAPC, and the saturation more than 95, less than 95%, you should be suspicious, and you should not leave the baby like this. Yes, echo has been done and diagnosis is PPHN, and we are treating this. So no, strictly no, get the one more echo done with the proper history telling to the pediatric cardiologist. Moving, only one crux in that baby, echo can go wrong, but the clinical diagnosis cannot go wrong. So clinical diagnosis is supreme. Next case is 7 days old baby, asymptomatic baby with the murmur. He is having the heart rate of 145 per minute, saturation. Now you are clever, you know that to diagnose cyanotic congenital heart disease, you should do the saturation in all the babies. So saturation is 100%. Now you are more clever. You have checked the pulses lower limb also. It is also normal volume, no hepatomegaly. So there is only ejection systolic murmur on examination. Baby is otherwise healthy. So you will refer this as a cyanotic congenital heart disease. Should we wait for the echo or to do the echo earlier? This is a 7 days old baby, relatively asymptomatic. In this patient, this is the real life experience or scenario. Echo was done at 9 p.m. has been sent to me by our senior pediatrician, and this echo has showed this is a severe aortic stenosis with the normal LV function. See, severe aortic stenosis, obstructive lesion is severe. Any point of time, this baby can go for the dysfunction and needs early addressal of the obstruction. You have to remove that mechanical obstruction. Unless and until you remove that obstruction, baby will not make it up. In the next 18 hours from the echo, that by 4 p.m. next day, baby was in cath lab and having the LV dysfunction. By the time of taking the balloon through the femoral artery, baby was in shock with the mean BP of 22 mmHg. And somehow I was lucky in this baby that everything went on time, balloon inflation has been done, and life has been saved because of the timely referral and intervention only, and at the time of discharge this baby was. So similar thing can go with the coaptation of aorta, also dysfunction. I will not go into the details of the cardiac imaging. This was our another small baby with the coaptation of aorta, the smaller babies. So importance of any neonate with the significant grading of the murmur, one should not wait. Yes, if it is a BSD or it is a Pedia asymptomatic baby, it will not have any kind of worst prognosis. But if it is an obstructive lesion, definitely it can go worsen in few hours also. So one should not wait, as early as possible. Send this baby. If not possible to send the baby, at least at a regular point of interval, even 12 hourly or 24 hourly, monitor this baby. If any sign of dysfunction or congestive heart failure, defer earlier to this baby. Then we will move to the next case, that is the 15 days old baby with the diaper rash and visiting to the OPD. Obviously, diaper rash, baby cranky and all that things will be there. Birth history, nothing significant, and there was no murmur at discharge. You were the only pediatrician who has attended this baby's labor call, has seen all the first and second day of life, and baby was having no murmur at discharge. And now the same baby has came to you at 15 days of life, and you got the murmur. Baby is otherwise healthy, weight is 3.4 kg, afebrile, heart rate is okay, murmur is grade 3, saturation is okay, respiratory and pulmonary upper abdomen system is absolutely okay. Again, the diagnosis can be the cyanotic congenital heart disease with left to right shunt, or another possibility is the obstructive lesion. Any possibility of the cyanotic congenital heart disease? No, not at all, because the saturation is 96%. Now, the moment you tell the parents that I need to get the 2D echo done of this baby, the parents' concern will start. At birth, sir, you were there. At discharge also, you were there. You told everything was absolutely normal. And now suddenly you are telling I am suspecting a heart disease and I need further evaluation. On top of this, not only you, our gynecologist and sonologist during the antenatal scans also told us everything was perfectly all right, no problem with the heart. And now again, this is the bomb on our head, that echo. Now, what is the your counseling session and what is your take? You will tell to the parents. First and foremost thing, you have not missed anything. Take out of your mind, you have not missed the murmur. Murmur was not there at birth at 24 hours of life, so you could not make it out. So you can tell to the parents, this is not a missed lesion. There are certain lesions which will present at late. This is a late onset lesion, because in a large BSD or a large PDA, murmur will not be appreciable during early course of neonatal life, because we know the PA pressures are high in first 24 to 48 hours of life, and it will take at least 48 hours for the PA pressure to come down to the 50% of what it was at birth. And then only the shunt flow will start, and then only we'll be able to make out the murmur. So there was no murmur at that point of time. So I would not ask for the congenital heart disease evaluation. Now the murmur is there. You get the echo done. We will see what it comes, and then we will manage it. If it is obstructive lesion, yes, it can worsen. And as the previous case, we need to take the earlier. So in this case, suppose if it is a PDA or the ventricular septal defect, till what is the further management in short, what is the further management of a patent ductus arteriosus or the ventricular septal defect? If the VSD is large, usually VSD or the PDA will have the same natural history. If the VSD or the PDA is large, usually they will be asymptomatic till 2 to 3 weeks of time. Once the PA pressures will fall, then only the large shunt will appear, and then the all the feeding difficulties will start. Baby will not gain adequate weight, and all recurrent respiratory illness and all that feeding difficulties will start. And if the shunt is very large, you may need to consider the early closure. But at least till 1.5 months of time, we wait for the PA pressure to normalize, and then only we will advise the surgical or the device closure for the VSD or the PDA shunts. On the contrary, if this VSD or the PDA is moderate size, baby is gaining adequate weight, no recurrent respiratory tract illness, adequate weight gain is there, moderate to mild feeding difficulties which are manageable. So these are the babies which we can manage with the anti-filiary medication. We will come to know what the role of fusimide, digoxin and enalapril in due course of time. These are the patients which we can manage medically and try to make them bigger. We can operate the baby at birth also at 2 kg, 2.5 kg. But wherever there is a possibility and wherever there is a chance, we try to delay this surgical management, because more weight, chances of success is more, less weight, chances of success is less. So ideal scenario, moderate to smaller shunts, we can wait. Smaller shunts, again, it may get closed spontaneously. In the VSD, smaller muscular VSDs, maximum chances it will get closed. Even the moderate size muscular VSD, even sometimes larger muscular VSDs will also get closed. So again, the type of VSD is also important. If it is a perimembranous VSD, then the chances will be the 50-50. But even if it is a moderate to small shunt, one should wait till the closure. One should not harp on the closure, because I may get the most of the times report, our baby is 1 month old and there is a lesion in the heart and we wanted to operate. This is not the decision to be taken by the parent. This is the collective decision by the pediatric cardiologist and the pediatrician. If the patient with the large shunt not making well with the medication, that is anti-filiary medicine, he needs surgery. The guidelines are very clear cut. Recurrent respiratory tract illness, CHF, no weight gain. Needs early surgical or the device closure. If the baby is making well, then wait. Then the absence of, from this, the previous case, what is the most important is absence of murmur at birth does not exclude the congenital heart disease, shunt lesion. So absence of birth, absence of murmur at birth, do not tell to your gynecologist. Most of the times they will be hurrying. Yes, can I go ahead for the permanent contraception or not? We cannot tell just based on single point examination that this baby is not having congenital heart disease. Certain diseases are there which can come with the time. Often the murmur will appear when the PA pressure will regress. And auscultation of a newborn on each and every follow-up visit is must. Initially, murmur may not be there. Murmur will appear over the period of time. This is the cardiac catheterization. We will not go into the details. The next case is 3 months old baby with the 4 kg, and there is a history of feeding difficulty and rapid breathing. The baby was all right till 1.5 months of age, and now the fast breathing has been started initially, and it has increased to the present state. And now the difficulty in that there is a tachypnea at rest also. There is increased forehead sweating and suppressed cycle also. So if you can see this video, this is difficult to run the video. Okay, so we know that there is the subtle retraction of the subcostal and the intercostal, and unless and until you take out the clothes of the baby, you will miss on that. So each baby, whoever comes to your OPD, you should be able strip it at least the chest part and see for this tachypnea under retractions. If it is there, even the murmur is grade 1 or grade 2, it can be the large shunt and send this baby to the further evaluation. And in this baby, there was a loud P2 and ejection systolic murmur. This baby was in the CHF, and of course, the diagnosis, it can be the large shunt. So we have discussed in short the previous management of the large BSD and the large PDA. Another possibility, if the saturation is less than 95%, which can be anything between the 88 to 95%, this patient can have the cyanotic congenital heart disease with the increased pulmonary blood flow, and the disease can be the obstructed TAPBC, tricuspid atresia BSD, or the TGA BSD. And these are the babies who needs the early referral and early surgical correction. If you are going to wait on this baby will succumb with time, and you need to start the decongestive therapy or the anti-failure medications to this baby. And of course, you need the echo to confirm the diagnosis and further management as far as the echo gives you the diagnosis. Then apart from the congenital heart disease, another this thing is the group of disorders, that is the dilated cardiomyopathy. Mind you, we were worried about the DCM, that prognosis, once it is done, it is the worst prognosis. This is not the case. You can see the chest X-ray, how the heart was there, Bade Dilwala, and with the hepatomegaly on the X-ray also. And this was the child, and this X-ray was just 1 year before this presentation. Within 1 to 1.5 years, she has improved a lot, and she was living a almost normal life. So dilated cardiomyopathy, if it is beyond infancy, the prognosis is good. In 60 to 70% of the cases will wake up, 30 to 40% of the cases will not wake up. So it is the guarded prognosis, but we never know who will come into the 60-70% and who will come into the 30-40%. So never give up, continue your medical management. This was the large PD and severe PH. This, no pediatric cardiologist will like to put this kind of a large PDA device. This is actually a muscular VSD device in a large PDA patient. So avoid this. Only how is it possible to avoid this? If you refer your patient in time, and they will be operable easily, and they will have smooth post-operative course. Sometimes we may get the 2 lesions in the same baby, that is the VSD and PDA, and we can tackle with in the cath lab also with the 2 lesions doing the same time, managing the same time. We have very few cases now, 2 cases. In short, I'll run this. So far, any questions or anything would like to be added by the Patil sir?
Or no, everything is going so fine, and we are all ears. Okay. So please go ahead. We'll have some summing up session or queries from chat box if they are there, or whether delegates or attendees can interact
in between. That is also.
Or if they are not, then we may take the questions from chat box.
Yes. Yes.
Please go ahead.
Yes. So the next case is he is a 10 years old male with a history of on and off headaches since last 6 to 8 months, and this is the same child who has presented to you with a around 5 to 6 years with the lower limb pain. This was usually on running or on exertion. This was a vague history, may not be possible to get in each and every patient. You did the examination of this patient. Weight is okay, his febrile heart rate, everything is okay. S1, S2 is normal, no murmur, respiratory, per abdomen, CNS, everything is okay. So what are the additional findings? 10-year-old male with the headache on and off. Only one point from the cardiac point of view I would like to make on the examination, and that is the femoral pulses. Touch the feet of your patient, you will get the diagnosis. What it can be the cooptation of aorta. We have the senior pediatricians like R.D. Patil sir and many here who will auscultate in such patient on the back in the interscapular region, who will make the continuous murmur of the MAPCAS, that is the collaterals, and send the patient to me that this patient can have the cooptation of aorta, please get the diagnosis. So that is the beauty of the clinical examination. If you thoroughly examine the patient, you can give the diagnosis at par to the newer modalities like the echo and all that. One more additional finding, this patient was having the hypertension also. Upper limb BP of 146/92 in a 10-year-old child. This is a hypertension definitely. As opposed to the lower limb, it was only 100%, 100 mmHg, the systolic BP. So clinically, this diagnosis has been made. This is a coarctation of aorta, needs early referral and further treatment. ECG, you may get if you have the availability. LV forces will be the predominant, which suggests the LV hypertrophy. Management is very easy once the diagnosis is made. That we can put the coarctation of aorta, the stent at that point, or surgically our surgeons can manage. Preferably stenting in the 10-year-old male, 10-year-old male or female. Similar patient I have who had the girl child with a 3 years age and who has been followed up for 2 to 3 months as a case of dilated cardiomyopathy. And twice the echo has been done, and she was, this is not the new story for me. Once in 6 to 7 months, I get patient like this. The patient with the echo has been done, dilated cardiomyopathy, and with all anti-failure medication. But one of our senior pediatrician, well-versed pediatrician, has picked up the weak femoral pulses on the clinical examination and referred to me with saying that can be the coarctation of aorta, and echo has been done, and it was the coarctation of aorta. Balloon dilatation has been done, and the child is doing well. So clinical examination is very, very, very important not to miss. Even if somebody has given the dilated cardiomyopathy on echo, just get it. One more case I had similar to this, 8 to 10 years old girl in the medical college. She was admitted again with the dilated cardiomyopathy. Echo has been done, dilated cardiomyopathy. With the postgraduate student has told me, sir, EF is only 25%, but she was having the hypertension in the upper limb. So why the patient with the dilated cardiomyopathy with dysfunction should have the hypertension, though in the initial phase of time? Why it should be there? It is coarctation of aorta. So we know, as very confident, I'll start the echo doing with the suprasternal view. And arch was absolutely okay to my surprise. So what it can be? Lower limb pulses were feeble, saturation was not well picked up on the pulse waveform, and coarctation of aorta at the arch of aorta, it was not there. But thanks to our senior teacher who has put in our minds that unless or until I do the diaphragm level pulsatility of the aorta, I document, I will not finish my echo examination. And similarly, in that patient, the coarctation of aorta was at the level of T78. That can be the Takahashi case, but this is how again the echo can be the normal, but with the suspicion only. No, this has to be the coarctation. Why not the coarctation? So if the coarctation is not at the arch of aorta, it can be the below. That can be the T78 or sometimes mid-thoracic level also. So suspicion is most important. Echo will not give the diagnosis of T78 level coarctation. So CTA angio has been done, and this patient has been with the balloon dilatation. So again, the coarctation is a mystery. One should be well versed with the clinical examination. This was our 20 years male with the coarctation of aorta, stenting done. Then we have in 20 years, 30, 35 years also, we have the coarctation of aorta. The lady who underwent twice the delivery. So coarctation of aorta, unless and until you do the careful clinical examination, you will miss the diagnosis. So coming to the medical management, so far we have talked enough about all the modalities. Furosemide, we have very limited medicines with us, and as Patil sir has rightly said, Samarth is backed up with this all oral formulation, that is the furosemide, digoxin at present. So when to use the anti-failure medications? See, the large shunt failure to thrive patient is in a CHF. You need to start the furosemide and digoxin in the early neonatal period till 3 months of time. Earlier, the patient is in the CHF, usually less than 21 days to 6 weeks of life. They may not require the anti-failure medication also because the PA pressures are high. Left heart volume overload may not be the evident, so they will not require the anti-failure medications. But after that, large to moderate shunts, definitely they will need the furosemide and digoxin. With digoxin, the earlier concept of digitalization was there to give the high dose. But nowadays, that concept has been gone away, and we just start the straight away patient with the maintenance dose, that is the 5 microgram per kg per dose twice a day. Oh, I'm so sorry. Am I audible?
Yes, yes.
Yes.
I think my screen has gone away.
No, it is there. It is there.
It is
You're
there.
audible. Yeah, it is
But
there.
I cannot move the screen and anything.
You
I
can
just
Stop
continue.
sharing and again start sharing.
No, my desktop is completely blacked out.
Okay. Is it charged or not?
No, desktop, I don't know, something technical glitch is there.
No, you can
I'll just
reach.
continue because otherwise I need to shut down the PC.
Okay.
Or should I continue like this only?
Yeah. You can go on orally without slides also.
Without. Okay. So the digoxin, the earlier concept of digitalization has been given away, and now just to minimize the side effects, and now we just go ahead with the maintenance therapy of the digoxin. The major importance of the digoxin is the rate control. It helps to achieve you the rate control. That is the sympathomimetic activity, as in overactivity is there in these patients. So we start the rate control. Mode of action is the most important, and again the cardiotonic effect of the digoxin is also well established there. Then why the furosemide? Furosemide is the, in multiple ways it helps. It helps for the diuresis, the pulmonary edema or the pulmonary congestion has also been taken care. But at the same point of time, the furosemide can cause the hyponatremia and hypokalemia also. If the furosemide causes the hypokalemia, digoxin toxicity will be worsened. So be cautious. If any patient with the high dose of the furosemide, be cautious about the hypokalemia. And in that patient, we may need to add on drug like the aldactone, which is a potassium sparing diuretic. So with this combination of drugs, you can manage the anti-failure medication. Usually the enalapril is, we try to avoid till 3 months of age, because the hypotension and all related problems must know below the 1 month of infant, one should not try unless and until the risk benefit ratio is well defined. After 1 month, cautiously one can use. After 3 months, easily one can use the enalapril. What exactly the enalapril does? It does it reduces the afterload. That is, the systemic BP has been lowered by this, and with a lowering of the systemic blood pressure, the pulmonary over circulation will be the prevented. So most of the shunt with the left right will be decreased, and more the blood will go to the systemic circulation, and that is how the effectiveness of the shunt will be the decreased. Again, with the caution, with the enalapril, one should not give along with the furosemide. At least 3 hour gap should be there to prevent the hypotension. So these are the only 3 to 4 medications we have, which has changed the management, and many patients we are able to tackle up. Even the large shunt, we will able to cope it up for the at least 2 to 3 months of time, and till they get bigger, at least even the 2.5 kg to 3.5 kg matters a lot for the pediatric cardiac surgeon. Operating in a 2.5 kg and operating in a 3.5 kg makes a hell lot of difference, and the success and outcome is much better in the morbid babies. Not only the operability, it is also the post-operative management for our intensivist and pediatric cardiologist. Also, in the post-operative period, the chances of sepsis is lower in these babies. So that is how the management of the with the medication we have. Propranolol is there. Again, the next slide is there of the cyanotic congenital heart disease, but I am not able to change the slide. So any cyanotic congenital heart disease patient you see in our population, most of the times with the rural patients, they may not, if you ask them to get the echo done, they may come after 15 days, 20 days or month, or maybe after few more months also. So any cyanotic congenital heart disease, you see patient, you start this patient on the oral iron, because cyanotic congenital heart disease, the body will try to increase the RBC production, and iron will be the relatively deficient, and dyserythropoiesis will occur, and due to this, the deformed RBCs, the chances of stroke and paralysis are very high. So to avoid this, you have to supplement these patients with the oral iron to prevent that dyserythropoiesis or to maintain the normal shape of the RBC. So start iron to any congenital cyanotic heart disease patient. Then there will be the few more slides of there, but unfortunately I am not able to move it. That upper limb and lower limb desaturation. Upper limb is perfectly all right, no clubbing, no cyanosis, but lower limb is clubbing. And this patient of 8 to 10 years old, and she has been came to me with the diagnosis of idiopathic PH and bunch of files, 6 to 7 files, and 2 of institutes have been seen. But again, I say that if you miss the clinical examination, you will never get the diagnosis. In this patient, the lower limb clubbing was there, upper limb clubbing is not there. We know differential clubbing, only one diagnosis is possible, that is the patent ductus arteriosus with Eisenmengeritis. And that was the diagnosis. Before doing the echo, I got the diagnosis. Obviously, PDA Eisenmenger, PDA shunting will be the bidirectional or more the right to left, and your echo expert will not be able to pick it up. Your clinical examination will give us the diagnosis. So then certain we have the cyanosis with no congenital heart disease. The differential diagnosis for the cyanosis without congenital heart disease. In spite of giving the oxygen, the saturation is not improving. It is persistently less than 95%. And you have done echo with your qualified pediatric cardiologist, which shows the normal. What it can be? It can be the methemoglobinemia. Another clinical clue for the methemoglobinemia, in whatever 5 to 6 patients I have seen, usually they will have greenish tinge into their eyes, that is the sclera. That gives you the provokes you that it can be the methemoglobinemia. Another diagnosis is the pulmonary arteriovenous malformation. We have 2 patients with the pulmonary arteriovenous malformations where I did the device closure, and patients are doing well after the device closure. So I think with this, we are coming to the end of the talk. And if anything, I would like to hear from the RD Patil sir.
Wonderful presentations, so many nice cases, and you have covered from day one to cyanotic heart diseases and even cyanosis without heart disease. Wonderful. Whatever we generalists and pediatricians should learn from this or otherwise also, the pulse ox is no more a gadget. You cannot practice without stethoscope. A doctor is known by stethoscope. He has to have stethoscope. Similarly, every clinician should have pulse ox in his examination chamber. No patient should go without pulse ox monitoring. And the single most many times, as Lalit has mentioned one case, that why that doctor should have referred the patient without any murmur, without anything cyanosis, then why he has probably referred this patient. And probably most important thing could have been the pulse ox and the saturation is less than 92% in the patient who is otherwise comfortable in OPD. Second most important thing about cyanosis is that, as he has rightly mentioned about in dark patients, similarly patients who are having low hemoglobin, less than 5 gram. So there is no enough carboxyhemoglobin, unsaturated hemoglobin, which will tell us that there is definite cyanosis. So pulse ox is the important criteria on its waveform, which is also very important. So pulse ox is very important. And in which cases we should really send for 2D echo in these patients. So whenever you are having a syndromic patients, even if there is no murmur, this definitely tells us that we should at least have one echo to rule out any congenital cardiac malformation or cyanotic or cyanotic heart diseases. This was a very important take-home message, and I appreciate for that. One more important thing is suddenly deterioration on day 2 or day 3 or after 12 to 24 hours in otherwise a healthy neonate. All ante should raise for a drug dependent conditions if they are recognized early, and if till the patient reaches to cardiologist and cardiac surgeon, if we can give prostaglandin, that will make definite difference in such a patient. And also obstructed TAPVC has to be suspected and kept in mind. And very important clue, we had suggested that we all know that in venous saturations PaO2 is always less than 50. But if umbilical, because in neonate it is very easy to get, and if the PaO2 is more than 100, that gives you definite there is a subdiaphragm, infradiaphragmatic TAPVC is there. So two very good cases and so many take-home messages were there. Similarly, in transposition of great arteries without shunt, if this is not taken up early, the left ventricle gets involuted, and even if the surgery is done, that it will not be able to sustain the pressure of aorta and systemic circulation. So after involution, it becomes the prognosis becomes bad. So early recognition and intervention is most important. And I think many times we pass off the asymptomatic murmurs, but particularly in neonates, no murmur should be passed off as a functional murmur or hemic murmur. Any murmur in neonate has to be evaluated. That was a very important take-home message. Similarly, as a clinician, I cannot harp more or overemphasize it that forelimb BP and forelimb saturation is very important. And I still remember one of my colleagues' son was having brought to me. Then I took a sent for 2D echo. He was diagnosed to have ASD, but somehow I was not happy. I took blood pressure, and blood pressure in upper limb was more than lower limb, actually, which should be the reverse case. The lower limb BP should be more than the upper limb, even if there is no hypertension. I sent this patient to senior pediatric cardiologist, Dr. Bharat Dalvi, 20-25 years back, and he had sinus venosus ASD with coarctation of aorta. And both the parents were medical postgraduate doctors, and he has completed his now from IIT Mumbai is BTech.
Great.
So these clinical examinations are very important. Now, one question I have got for Lalit is that why digoxin has taken a back burner situation or back bench? Because we know that enalapril or all these S inhibitors, they are also having this 2A evidence. Diuretics have definitely level 1 evidence or evidence A, but for the ACE inhibitors and digoxin, it is a 2A inhibitor. So at least in acute heart failure, it may not have that much situation because we are not doing a loading digitization now. But in chronic heart failures, and where is the actually role of digoxin now? And vis-a-vis comparison ACE inhibitors, because we know ACE inhibitors will be only tried for left to right shunts. And if there is no renal artery stenosis, bilateral renal artery stenosis, or if there is no allergy. So I just wanted you to decipher more on the role of digoxin, particularly in chronic heart failures and in other cardiac conditions, particularly in children.
Yes, sir. The role of digoxin is still valid in the chronic, as you rightly mentioned. It is most of the times only nowadays reserved for the chronic conditions. In acute conditions, most of the times the baby will be the hospitalized, and here we have the better options. That is our inotropic agents, that is the dobutamine and all others. Depending upon the cardiac lesion, we have the option that if we want to increase the afterload, we have the dopamine. If you want the cardiotonic effect, we have the dobutamine, and so on, the noradrenaline, adrenaline. So with the availability of this, the newer generation cardiotonics and the availability of the easy availability, and more people have learned about all these medications, the digoxin has taken the backseat due to the availability of all this. But the chronic patients or the long-term patients like our congenital heart disease, where we want more time, that 1 month, 2 months, 3 months time, there definitely the digoxin has a role. And most of the times, though the digoxin, all the 3 to 4 ways of mechanism of action has been told, it has some cardiotonic effect also, sympathomimetic also, and rate limit also. The most important role of digoxin nowadays for the chronic is the rate limiting, where it limits the rate, decreases the sympathetic drive, and try to prevent the heart failure, or try to maintain the baby with the whatever the status quo is there with this, and preventing from further progression to the CHF. So this is the only limitation of the digoxin, because it is actually not the limitation, it is the actual availability of the other better agents in the acute setups. And compared to that, the toxicity of the digoxin with the digitalization is very high. And sometimes we also see in the patients that they will misdosing has been done. Suppose sometimes our dose is 0.1, 0.2, 0.3 like this. If they give in this in ml, the vomiting and all the other problems will start, and the baby will have feeding related further issues and all that, and we may end up in the problem. So that is the only, these are the two reasons due to which the digoxin is little bit cautiously used. But in the elder patients, we can use safely. And we have the big history of rheumatic heart disease where the digoxin has been used for the so many years.
So its role is there in chronic heart failure.
Yes.
And with maintenance dose,
Yes.
the simplified dose will be 0.01 milligram per kg, and it should be divided into doses.
Yes.
And there is no need of any weekly holidays for digoxin.
Yes, sir. Nowadays that is also because we are giving only maintenance therapy.
And it should be particularly chosen in chronic heart failure, because as you have said that it decreases definitely heart rate, it decreases aldosterone action, it decreases sodium reabsorption, it has a baroreceptor function. So many things are there. But as you have said, in acute condition, it has definitely taken a backseat because it needed acute digitalization in acute cases. But chronic conditions, it still has got role, and we should not forget such a wonderful drug in chronic heart condition and chronic congestive heart failures. So, but we have to take due care of not giving any loading dose, only maintenance dose has to be given. One more question from my side is that when you will call a murmur as a functional murmur, and secondly, once you have diagnosed your cyanotic congenital heart disease, how frequently we should do the reviewing of the 2D echo in cases of shunt and in cases of obstructive disease?
Yes, this is very important question, sir. Functional murmur. I really feel I am blessed as a pediatric cardiologist. I have the power of echo with me. See, if I would have been practicing as a pediatrician and doing auscultation of each and every baby, then I would also have been gone wrong for at least 50% of the times. See, murmur diagnosis is really difficult. It is not that easy. Functional, I would like to say grade 1 or grade 2 murmur is most of the times they will be the functional. It can be the hemic murmur, or sometimes in the neonates, it can be the due to the branch pulmonary arteries flow acceleration murmur, or sometimes the venous flow acceleration murmur. Sometimes if persistent left HVT is there, it can also cause the give some kind of flow related murmur, or for that point of time, sometimes right SVC flow acceleration will also give the murmur. But grade 1 or grade 2, any murmur which is very easily audible, then definitely that is not a functional murmur. That is going to be definitely the organic murmur. Then the next question is that is how frequently we should do the echo. For the large shunt, basically if it is a ASD less than 5 millimeter. Now we have recent publication in the IAP also with AIMS peoples and our beloved Saxena madam, that big group, that less than 5 mm ASDs have maximum chances of closure. Initially we used to follow up, give the 6 months follow up, but I feel less than 5 millimeter ASDs follow up, we can say once in a year, or directly sometimes if the parents are well educated and they are bound with the pediatrician with the regular visits, one can ask for the follow-up at 3 years of age also directly, if not earlier. This is for the smaller ASDs which have having the size less than 5 millimeters. Bigger ASDs like 6 to 8 mm and all that, I feel in these ASDs every 6 months follow-up is very much necessary. If the ASD is very large, first diagnosis of ASD, which is more than 10 to 12 mm, I feel first follow-up should be after 3 months. And if the baby is doing well, then every 6 months for the ASD, one can do the follow-up. On contrary to this, if I see the VSD or the PDA on say 10-15 days of life, I see the moderate size VSD or moderate size PDA, baby is relatively okay, asymptomatic, but I don't have the exact idea of the PA pressures. I have to write that I may get the gradient of 25-30. So I don't get the exact idea whether this is going to have the persistent PA pressures high or with time the PA pressures will regress. So I would like to see this baby at 1.5 months of time, because not only the PA pressures idea I will get, but at that point of time, I'll get their left heart volume overload also. If this baby is going to have left heart volume overload, in that case, I need to start this patient on the digoxin and furosemide. And once this 1.5 months echo has been done and baby needs medication, this patient I would like to see every 3 months. If medication is not required in these patients, then I would like to see these patients every 6 months. If it is just a tiny here and there, just a minuscule of the PDA, in this PDA, I would like to see directly at the age of 1 year or at the age of 10 months, because this is the time, or the guidelines has been told that one can wait for the asymptomatic PDA till 10 months to 1 year of age. After that age, any asymptomatic PDA with audible murmur, one needs the closure. So PDA, minuscule PDA, asymptomatic patient, initial diagnosis and 1.5 months diagnosis, then directly at 8 to 10 months. VSD, if it is on contrary to the moderate or small size, if it is a large size VSD, then definitely this may need the close follow-up. If the first follow-up is at 15-20 days, second definitely at 1.5 months of age. If the baby remains symptomatic with medications, I may see this baby after 2 to 3 weeks also, or a month also. If the baby remains symptomatic in spite of medications, I need to take a call that this baby needs the surgery at earliest. One cannot wait, because in a large shunt, large VSD or PDA, if I wait, the literature in India and worldwide at present says large shunt in operated by 6 months, mortality is 50%. They may succumb to the respiratory tract illness, and there will be the end of the story. So to prevent all that things, I would like to take the regular follow-up for the large shunt babies.
Wonderful. That was a very detailed and very important take-home message about doing the, because we pediatrician will need how frequently we should really send, or they ask whether we should do the 2D echo. So it will depend on the size of the shunt, level of the shunt, and type of the shunt.
Yes, exactly.
So very important information. And also for functional murmur, we have to see the patient in toto, whether he has got failure to thrive, whether his saturation is something abnormal, whether he has got other signs of failure or not, that then that definitely, otherwise a hale and hearty patient who is having a very short systolic murmur, then these murmurs may not need the evaluation. And age group also. So any murmur in neonate cannot be a hemic murmur. Yes. So that was very enlightening lecture. I am very happy to listen to one of the best lectures. So if there are any questions from chat box, we'll take it. Otherwise, I would like to hand it over to Mr. Prashant Dave.
Just one question. Since you were mentioning, Dr. Lalit was mentioning about the inotropes, dopamine, dovitamin, and all. So levosimendan is a calcium channel sensitizer. Yes. So
yes.
So basically, so we just wanted to know how can that be explored in these chronic cases? What is the role of that?
Again, the levosimendan, it is recommended only for the acute, and when usually rather than these patients, our shunt lesion patients will not have almost 90 to 99% of the patients will not have severe dysfunction. So we don't want that much kind of cardiotonic agent. Levosimendan we use in a patient with the severe dysfunction, which can happen in a patient with a dilated cardiomyopathy. It can be the intrauterine cardiomyopathy, or it can be the post-viral myocarditis cardiomyopathy. It has a role in these patients, and the congenital heart disease post-operative patients who go for the dysfunction, who have the longer bypass time, on pump time. These are the babies. So levosimendan is mainly used in the post-operative congenital heart disease ICU. And in the pre-operative cases, most of the times its usefulness is towards the severe dysfunction with the dilated cardiomyopathy and all that. In the obstructive lesions, severe dysfunction will not help to any kind of your drug, because we know this is secondary to the obstruction, unless and until in all the patients with the severe dysfunction with the coarctation or the aortic stenosis, I don't start them on any kind of inotrope, because I know unless and until I'll relieve the obstruction, this patient is not going to get any kind of benefit. So levosimendan has limitations, has definitive role, but in case of the severe dysfunction patients, and that category is little bit selected at present. And sometimes in the supraventricular tachycardia also, we have gone for the dysfunction.
Thanks.
Otherwise, in PICU also,
Yes.
levosimendan, if all metabolic conditions are corrected, anomalies are corrected, and if still this patient is not responding to this thing, inotropes and vasopressors, shock, hypotensive or resistant shock, there in PICU situation, other than non-cardiac condition, we may think of using a levosimendan. But my personal experience is not there with levosimendan, but this is the review of literature.
Yes.
So I think, Prashant, if there are any questions,
Prashant.
not, and then we can then call it a day.
Right. So one of my queries was with respect to levosimendan, because we are manufacturing and we are supplying it abroad. We're thinking about also launching it because it also saves time if there is with respect to the any surgical operation, surgical options that need to be explored, and it buys that little bit of time for some of the patients. So yes, that was it. And thank you very much, Dr. Lalit, for such an enriching session on managing congenital heart disease made easy. Our entire endeavor about Pedia Connect webinars was to enable the primary caregivers, especially the pediatricians, to better manage and diagnose pediatric heart failure. Thank you, Dr. Ramakant Patil, for being, with the busy schedule that he has, to come and moderate this session. It is an honor to have you here in our Pedia Connect webinar. Thank you everyone for Pedia Connect for attending the Pedia Connect webinar on managing congenital heart disease made easy from Samarth Life Sciences family, which are the proud manufacturers of Dixin, that is digoxin in the syrup formulation, as well as Furoped, which is furosemide again in the syrup formulation. We look forward to your participation in the entire series of webinars on Pedia Connect. You can log in to our YouTube channel, that is Doc Academy, in order to listen to any of the recorded sessions of all Pedia Connect webinars. That's all for today. Thank you very much.
Thank you. Thank you all. Thank you,
Thank you very much, sir.
Thank you.
Thank
Bye.
you,
Have a
sir.
great
Thank you.
day.
Thanks,
It was
thanks,
my
sir.
pleasure.
Thanks for it. Thank you.
Thank you, Pandita sir. Thank you.
Thank you, sir. Thank you, sir.
Thank you, Dr. Saab Sanjay. Bye. Have a
Thank you,
great
sir.
day.
Yes.
Bye-bye.
Yes.
Thanks a lot, sir.
Thank you all.